the permission of our president, sir, can we start this meeting now?
Yes, please, Ravi.
Okay.
Can I say a few words?
Yeah,
Yes.
I will ask you. I will ask you in a minute to say,
Yes.
give a welcome address to our members.
Yes.
Just give me a second. Okay. So, good evening, members, esteemed members. So, on this occasion of 50th anniversary of the annual conference of the IAPS Con, it is truly an honor to welcome each of you, all our senior members to our surgical community to this gathering. Sir, all your dedication, expertise, and commitment to advancing the field of surgery are what make our profession both a privilege and a responsibility. So, as we gather here today, we recognize the profound impact you have had not only on the lives of countless patients, but also on the generation of surgeons you have mentored and inspired. Your tireless efforts have laid a strong foundation upon which our community stands. Each procedure you have perfected, every innovation championed, and every young mind you have guided has forwarded and contributed a legacy of excellence that will endure. Our world of pediatric surgery is ever evolving, and yet it is the wisdom and resilience of our senior members like you that provide the stability and direction needed to navigate the new challenges, whether through groundbreaking research, exceptional patient care, or influential teaching. All of you have set standards that push all of us to the better and more compassionate surgeons. This gathering, which we are doing today, is also an opportunity to celebrate and acknowledge the depth of experience you bring to the table. We hope this forum serves as a space where we can continue to learn from your insights and together advance our shared mission to provide the highest quality of surgical care to our pediatric surgery patients. On behalf of the entire pediatric surgery community, we thank you for your enduring commitment, leadership, and passion for surgery. And here is to the accomplishment we honor today and the future that we will shape together. I welcome all of you for this IAPS Senior Members Lounge. We have a specific structured program here today where we will have 6 to 7 speakers who will speak on some specific topic that we have requested them and share their insights and experience and their wisdom with the community of the IAPS. Before we begin with our structured program, I would like to invite Dr. Meera, who has been coordinating with me today, and to speak a few words about this meeting and welcome our members. Dr. Meera, please.
Thank you, Ravi. So this starts off from a fact that Vikesh has suggested, and we started off, there was a women's meeting of the senior surgeons encouraging the other women. And then we said, why don't we replicate it and make it open to all the IAPS members? And from there on, we started and we decided everybody suggested a few names. Although we've invited many more names and Ravi has been pursuing them, but we got a few to join. But we would like others as we go along to speak up and join us. And we've got a few junior members also to take their opinion. Over to you, Ravi.
Thank you, Dr. Meera. So now I will request our President IAPS, Dr. Ramesh Babu, to say a few words of welcome and gratitude towards our senior members. And after that, we will start our program.
Yeah, I first of all thank all the senior members who joined here.
Sir, you switch on your video, sir.
Well, the Zoom is kind of little odd behavior these days. As I said, it is not allowing me to open the video. I'm sorry about that. My video is on, but it is just not showing my face. I don't know why. But you can hear me, right?
Yes.
Yeah.
Can hear
See,
you.
IAPS itself is 57 years old, and IAPS Con is 50 years old. So we are celebrating the golden jubilee of our conference. But some of the members who are here, their experience as a pediatric surgeon is actually more than 50 years. We should remember that. They have seen the period where IAPS was a subsection of the ASI, Association of Surgeons of India, ASI. And then they have also seen how the pediatric surgery has developed from the scratch. And although we are in a very enviable position here today, sitting as some of the office bearers of the IAPS, the struggles and the number of brainstormings these people, the senior members who must have done those days to set it up for us. This is not an easy joke. I mean, if you want me to start a new association and then set it up from the scratch, I would really be struggling. So we actually stand on the shoulders of these giants and honoring our senior founder members whose vision and dedication has laid the foundation of IAPS, their pioneering spirit, unwavering commitment, all of it. They've let the shape the path we follow. They've guided us and they continue to guide us. So it is only befitting that we ask the senior members. This is a custom in our family. We always ask our senior members to start any function in our house. We seek the blessings, and being a golden jubilee IAPS con, it is only important that we ask the blessings of our senior members and hear their words before we actually start our conference. And I thank all the senior members. I wish a lot of junior members also join and then learn from the words of wisdom from every senior member. Thank you so much. Please start.
Thank you. Vikesh, would you like to say something at this point?
I will be very short. As being a pediatric surgeon, I am half child. So I also share the same feeling that without my elders, my parents or my grandparents, I won't start anything which is auspicious. So as this is 50th IPS Con, I'm very happy. I express my Charan Sparsh in front of all seniors. Thank you.
Thank you, Vikesh. So now we will start with our planned program. I would like to welcome all the speakers that we have shortlisted. I can see Professor Ravi Kumar is there in the meeting, Dr. Ketan Parekh, Dr. Raina, Dr. Mohan Abraham, Dr. Kailan Rao, I can see is there. Sir, welcome. Dr. Sumitra Viswas, Dr. Meera is already there. Dr. Jyotsna Kirtane was supposed to join. She cannot join. She is busy with some family function. And Dr. Saroj Churamani Gopal is there. Good evening, madam. So we will first start and take the blessings from one of our senior most member of IAPS, Professor Ravi Kumar sir, who can say some words of wisdoms and blessing to all of us. He is senior most amongst all of us, and we would love to hear from him. Ravi Kumar sir, can you hear us?
I can hear you.
Over to you, sir. You can speak.
Are you able to hear me?
Yes, sir. We can hear you very clearly. We can see you as well.
Right. Since the time that you have given is very short, say about 5 minutes, instead of talking extempore, I thought I would just read what I have written. That will be much more convenient because you can finish within the time. So, esteemed members of the Indian Association of Pediatric Surgeons, I thank the organizers for asking me to give the introductory remarks on this historic 50th annual conference of the IAPS. My talk will be followed by talks by other senior members who have vast knowledge to guide youngsters in various aspects in the field of pediatric surgery. The talks are spanning from setting up of pediatric surgical services by Professor Ketan Parekh, and then addressing the unique challenges of women by Dr. Jyotsna Kirtane and Dr. Churamani Gopal, and the women power in pediatric surgery. They signify the diversity and depth of the expertise within the Indian Association of Pediatric Surgeons. The women power is obvious, not only in IAPS, but throughout the world. Now, Kamala Harris is almost on the edge of winning an election. And then even here, we find nearly 50% of the speakers are women, in today's function. I have been a member from 1969, when the pediatric surgical section was part of the parent ASI. In the last 5 decades, the IAPS has made significant contribution in shaping pediatric surgery in India. There was a period of early challenges, limited resources, fewer specialists, and lack of public awareness, and these hurdles have overcome in the last 50 years. I remember very well that only one child with a tracheoesophageal fistula survived in the Institute of Child Health between 1969 to 1974. And now the scenario has changed and more than 95% survival now. I vividly remember the photographs sent by Professor K.L.N. Rao in Chandigarh, that in one night, more than 10 children were operated in Chandigarh and all went home alive. I mean, it's a great feat. It indicates the progress that we have made in the neonatal surgery, especially the pediatric surgery. I express great pride in witnessing the advancement of the younger generation has achieved, noting the resilience, innovation, and dedication that newer members bring, especially in various social groups. I find excellent videos of laparoscopic surgery and then robotic surgery have been demonstrated by very young fellows. Now, there is a strong interest in subspecialties like urology, research, oncology, and new techniques like minimally invasive and robotic surgery. I'm sure Dr. Mohan Abraham will clear the doubts of technophobics. That is, technophobics are those who do not accept the, the other word for technophobics is luditis. Luditis are those who will never accept a new technology and always question them. And then I'm 100% sure he will tell the advantages of the robotic surgery over a laparoscopic surgery, and it is going to come in the years to come when the cost of the machine becomes much less. We have a great number of younger pediatric surgeons who will carry forward the legacy built by the doyens of pediatric surgery in the last 5 decades. Dr. Ramesh Babu, Dr. Vikesh Agarwal, Dr. Ravi Kanoja are the perfect example. They have raised the IAPS to new heights by continuously trying to create and implement innovative ideas. I thank the organizers for inviting me to give the opening remarks and being a part of this event. I appreciate the organizers for arranging organizers for arranging this wonderful conference. Thanks for every one of you who are assembled here, and I look forward to listening to all your lectures. Thank you.
Thank you, sir. Thank you so much for your words of wisdom. And we hope to hear more from you in the coming years. And we will miss you at the IAPS physical event, which will happen following this meeting.
Yeah.
So now the topic.
I am now 87 plus. I mean, I have become old. I mean, not super senior. I belong to old. And then, the classification of the old age is now from 60 to 74 is considered as young old. And then 74 to 85 is considered as old. And beyond 85 is old. And I belong to the last category. So the travel has become a little difficult. Thank you. Thanks for calling me to speak.
Thank you. So it's really, truly inspiring to hear from you. So now the topics that will follow is actually a short collection of some topics that we thought that would enlighten and enrich the interaction between the seniors and the juniors. We will start with Dr. Ketan Parekh, who was very keen to indulge the interest of the junior and the mid-career pediatric surgeons who want to set up a pediatric surgery service or look for the career options. So we would like to hear now from Dr. Ketan Parekh, who will talk on how to set up a pediatric surgery service and career options for junior pediatric surgeons. So Ketan sir, over to you. Please start.
Good evening, everybody, and Ravi Kumar sir, regards to you, and of course all the other seniors also who are here, Dr. Shuramani Gopal. And I'm not going to say much about, I thank all of you for organizing this meeting. And so can I share my screen?
Yes.
Yeah. Is my screen visible?
Yes.
Visible.
So what I am going to talk about is to start a pediatric surgical facility, and why, of course, why not also, and how. And so what I am going to talk is mainly suggestions, and please, if there are juniors sitting here, they should see their situations and circumstances and accordingly decide what to do. But we all have to remember that our speciality and status is only as great as what we make it. Because I often see in the meetings that people are expecting pediatricians to help us to grow our status. I don't think that is going to be possible. Neither surgeons nor pediatricians are going to help us. It's we who will have to improve our status and keep on improving it over a period of time. Why should we have a entity or a pediatric setup? Why should one create this? So why we need to create an entity for ourselves? Well, when in my case, I had seen that till then pediatricians and other doctors used to use us as subsidiaries on a per case basis, something like how they call an anesthetist and then he comes and goes away. Even most of the time, the patients don't even know who has operated them. Also, once you create a special entity, you show your self-confidence in yourself and your specialty. When you create a hospital or pediatric surgery, you are showing that self-confidence. You can also highlight the need for special facilities which you require for pediatric surgery. You can manage your patients to your satisfaction. You can have customized staff training can be customized, and over a period of time, you're likely to get capital appreciation for your premises. In addition, you also create a connection with your patients, because almost every 10th to 12th child is going to require some surgical intervention at some stage. So you create a following and loyalty because of a brick and mortar situation. Patients tend to connect more with brick and mortar rather than humans, and they will remember that at this particular place, pediatric surgical services were available. A lot of small work can come around if you have the time to do it. So CLWs and suturings and abscesses, which normally we may not human, but still it gives you money, it gives you work, and it gives you a name and circulation in your society. It's easier to learn in your own secure premises because you don't have many more people watching you when you are learning. And at least for me, when I started doing minimal access surgery, that was great because I should take 2.5 hours to do a lap appendix, and there was nobody else to see that I'm taking that much time. And I could it was only my anesthetist and my team, so nobody had to grumble about it. You can also oblige patients, you can oblige doctors by necessary discounts, but we have to be careful that we don't overdo it because that's going to eat into us. A hospital can be marketed because as yet it is not controlled by medical council rules, and then you can do a marketing for a hospital, and patients can get admitted for medical conditions. If they get admitted for medical conditions, you can call the pediatricians and oblige them. So why not to make it? Well, the headache. It's crazy, of course, but then one has to remember that there is no gain without pain. Now, how would you go about making one? First and foremost, identify an appropriate spot, preferably a middle class area, so that all categories of patients will come more easily in a middle class area. In an area where parents are younger, if you have an area where majority of the population is senior citizens, then you are not going to get enough patients. The place should be easily accessible. If you have parking facilities, that's going to be a bonus. Harp on clean surroundings, because we are harping on specialized facilities, and a clean surroundings is going to be very important. If you are starting your own place, aim for a minimum of 8 to 10 beds, at least 2 to 4 ICU beds, but preferably more than this if it can be done. Maybe in Mumbai it is difficult, but in other towns it's more possible. Stress has to be on openness, and it should be a different feeling. Your patient should get a different feeling. They should realize that they have come to a very different place at a lesser cost. You have to sort of create a value for money. Don't unnecessarily spruce up your place so that it becomes an expensive place, but still show that it is different. You must know the local rules, preferably study them, read about them, Google, ask seniors, ask the association, ask IMA before you make your place, because you should know all the local rules. And as far as possible, don't break them. You may bend them here and there, but if you break them and if you get stuck in a court case, you're doomed for the money and also the reputation. Local rules involve the municipality, the Clinical Establishment Act, fire safety, biomedical waste management, staff salaries, minimum wages have to be given. If you are going to have a radiology or a sonography setup, then additional rules are applicable. You'll be surprised that even your weighing machine, where you weigh your children, has to have standards. So these are the sort of rules which are there. That's so ridiculous, but they are there. One thing one has to be remembering is that avoid dependence on local goons, because they will demand their pound of flesh at some time. So please keep a little distance from all them. They will try and tell you that we will help you in every way because they want to oblige you so that they can ask you for a return obligation. Finally, try and get partners. Pediatric surgeons, well, that's ideal. If you can have pediatric surgeons as partners, you can take urologists, you can take ENT specialists, you can take plastic surgeons. Medical branches, obstetricians, ophthalmologists may not be the best partners unless, of course, you are wedded to them, then there is nothing wrong in it. When you are preparing your place, you will realize that you need to compromise on certain expenses. Make a small note for your patients that this is the reason why you have compromised on unnecessary expenses so that their costs are less. You will realize that you have been thinking about it and still not done those expenses so that their costs are less. They will appreciate that. And well, for 34 years that I ran my facility, I can tell you, now I have shut down since the last about 1.5 years, but for 34 years that I ran my facility, I did not take surgical charges in advance. That showed the self-confidence in myself. My actual loss, monetary loss, was not even 5% in all these years. I had put up a notice that we do not want to harass you by insisting on full payment beforehand. You have put faith in us by handing over the life of your dear one. We have faith that you will repay the final bill, because if you do not pay, I will not be able to pay my staff and they will suffer. So you have to balance all these things when you are going to create a pediatric surgical setup. But if any of you are thinking of it, then all the best. And if at any time you require my help or my suggestions or my information, please do not hesitate to call me. Thank you very much. Any questions at any time, then you can either send it to me or I'd possibly put it in the chat box. So I don't know what is the scenario.
Yeah. Thank you so much, sir. Thank you. Your talk really brings in the unique sense, which is a combination of the corporate sense plus the philosophical aspect of how can we start pediatric surgery services. And I'm sure our youngsters, once they delve into the depth of what you have shown, they will definitely realize all the important points that you have made. I will request maybe Dr. Meera or Vikesh or Dr. Ramesh if they want to say something about what Dr. Ketan has just said.
So, if I can speak, I think Ketan's talked a lot of common sense, and it's easy to sit when there's a third person asking for money. But if it's your own assessment or somebody comes to see you in your home clinic, you don't ask for money first. It always comes later. And I agree with Ketan. There are few people who will give, even if somebody says, I don't have money, you tell them you can transfer it later. And the majority will transfer it. So I agree. If you are honest with them, they will be honest with you. We are going to have a few odd cases. That's different.
Thank you. Thank you. So we will move on to the next speaker now. Now, with all our senior members who are present here, they have a unique achievement of a situation that when they started during their younger years, they were all working with general surgery department. And then pediatric surgery, it was at their career stage when pediatric surgery got separated from the mothership general surgery. And then they had to start from scratch on how, they started the pediatric surgery. They must have struggled and had friction with the mothership in providing resources, fetching funds to set up the services. Our next speaker, Professor V.K. Rana, he will talk to us about how in a medical college, what is the general challenge when you co-inhibit with the general surgeons, and how you can manage and tackle your general surgery colleagues when you're working with them as a unit, not as an independent separate department. So, Dr. Rana sir, it's over to you. Please, you can start.
Good evening, everybody. My respect to Dr. Ravi Kumar, Churamai, Ketan Parekh. For youngsters, I'll have something which I experienced. You are lucky that you have you will be having a established department or established unit in the private hospital. But if you go where it is not working, then you have to keep certain things in mind. As Ravi has already said about it, that what will be the experience with the general surgeons. Now, when I joined there, my teacher, who was a general surgeon, was given a charge to start the pediatric surgery unit. He was doing whatever best he could do, he was doing it. I joined it. Now, when I joined it, I knew that there is going to be a clash because he's already working as a pediatric surgeon, but he's not trained. So there are many lapses. So I have to keep in mind that I should not have any fight with him. Number one, he was a practicing person. Another thing that I have to see that I don't come in between his interest in the patients. Okay. So, and what is your aim? Your aim is that you should get a good surgery. Like the Arjun was told about the parrot's eye. Don't see anything anywhere. I joined it. The same thing happened, that he started feeling uneasy. Sometimes in the round, he will say, oh, you don't know this thing. Sometimes when I put up a diagnosis of something, no, this is not, it's not there. Dr. Rena, it's not there. When then it comes out, then we say, acha, it has come out. Okay. I never back answered. I never said anything. Whatever cases he used to give me, I used to tackle with them. Sometimes what happens, once the case of diaphragmatic hernia was admitted, he knew he will not be able to do it. But he was a practicing person, so he has to maintain his image. So he said, okay, Dr. Rana, this is a very simple case. I'm sure you will be able to do it. Now, you know what is the trap in this? If the patient dies, oh, he doesn't know anything about this surgery. But if I am able to do it, oh, it was a simple surgery. So these types of tricks goes on, and you have to bear it because your aim is that you should get the surgery. Gradually, by time, he started giving surgery to me, and I started doing it. So this is one thing. Second thing is, in those days, there was no recognition of pediatric surgery. Even to the extent you will be wondered that when we joined, nobody was knowing how to use scalp pens. Now we are using intracats. And when I was taking training in the KM, I used to clean those scalp pens and used to preserve that I have to take these things because that will not be available in Jabalpur. The sister in charge was observing it. He said, why are you doing this thing? I said, this is the thing. So when I was coming back, in my room, a big parcel was kept. Written over it, don't open it here, open it only when you reach Jabalpur. And when I reached Jabalpur, it was having a lot of scalp pens, feeding tubes, and those times we used to put not intracats, we used to put the PVC tubes into the vein. So all those were there. So like this, I started the unit, and nobody knows. The first round when I used to take the round, then I used to take second round was, अच्छा भाई किस को ड्रिप लगाने का है, start that. Now see, the students are also interested in general surgery, not in pediatric surgery. Sometimes when I am doing the dressing, trying to demonstrate the dressing, how to do it in non-touch dressing, the house surgeon goes away. Then he comes back. Where were you? Sir, you were doing the dressing, so I thought I will go and have something and come back. So these were the things where you have to keep your mind cool. and work with the aim that you have to progress with it. Anesthesia. No anesthetist was having any exposure of anesthesia and that, except our head had a little bit exposure, but you don't get those senior persons. So how will you do it? The only alternative was to do with local infiltration that we learned in KEM itself. And now we have to do a lot of local infiltration. Sometimes I said it's a three months old case. So how can I give anesthesia? Like that they used to refuse. In emergencies also, I said, you are lucky that I'm here. You can learn pediatric anesthesia with my help. Don't try to postpone the case like this. But you will be surprised. In a case, I have done pyeloplasty in a local anesthesia because he was having a respiratory distress with a huge enlargement of the kidney to that extent. But this now today you will not see it because you have got trained anesthetist. And if you go to the institution, you have already got the background of that. But where you go where no any background, next is your pediatric colleagues. You have to make them convinced that it is a specialty where we are trained for that. Otherwise, they used to send the patients to the general surgeons like hernia or that. I remember one day, one of the senior staff on the general surgery was discussing with head of the department. I was also sitting there. Oh, what did you do? I also do meningomyelocele and he also do this and that. I said, what is the mortality rate of your case? Who come to know about it, it's not only the surgical skill, it is the management, the fluid and electrolyte, temperature, everything covers that. So like this, you come up and remember what you are doing it, you will get a fruit out of it. And now today, I'm very proud of it, that Vikesh is there running the department. And in the last, I would like to say one thing. When you become senior and the junior joins, he is bubbling with knowledge. He may be knowing more than you. A little bit psychologically, you may have something, a rift with him or something, but try to listen to him. One example I may give you, quoted here is that he was trained in laparoscopic surgery. I was not trained in laparoscopy. On the contrary, I may say his guru. He trained me in laparoscopic surgery. And when he came, I said, Baba, it will take a lot of time and all that. So how will you do? It's a lot of list we have to pay pending. Say, sir, no, sir. In the initial, it will be, see, he has got the power to convince his senior. And I had learned from it and I said, okay, you do. Then I decided that he will do it under general anesthesia laparoscopic. Meanwhile, I'll do many of the surgeries under local to cover up the group of the surgery which have been posted on that day. So like this is there. And I think my time is over. So I would like to thank you very much.
Thank you, Rana sir. Thank you so much for your words of wisdom. I'm sure all our junior and other surgeons will recognize and appreciate all the efforts made by seniors like you who have started the pediatric surgery services in your respective institutes. All of us, we got trained in departments which were already established, and we have actually not seen the struggles of how the problems can occur with our general surgery and other administrative departments that are associated with us. So thank you so much, sir. We'll move on to our next speaker, who is Dr. Mohan Abraham. He is one of our very senior members who has specialized and developed techniques related to pediatric minimal access surgery as well as robotics. I'm a big fan of his vesicoscopic technique, and I owe it to him from whatever I've learned for this procedure. And I would request Mohan Abraham sir to talk on how a pediatric surgeon, an early career, mid-career, or even a senior pediatric surgeon can adopt minimally invasive surgery as well as robotic in the current era, as it is the buzzword now. And everybody is looking, for minimally invasive procedures. So over to you, Abraham sir. You can speak now.
Thank you, Dr. Ravi. I mean, it's a great pleasure to see all of you and even my gurus like, Dr. Ravi and Dr. K.L.N. Rao, who really, helped me to come up in the field of pediatric surgery. I'm glad that, I could see them again over there. Now, can I share my screen?
So you can share. You can see, yeah, it's starting now. Yes.
Yeah. Now, first thing, like I started my pediatric surgical training in 1985. Not training, I started doing pediatric surgery in 1985. But then I had to wait for about, till 1993 before I could, start something on laparoscopy. Now
So
that's
can you
because
put it
in
on slideshow? Sir, can you put it on slideshow?
Yeah. So in 1993, I got the chance to go to Saudi Arabia. It is there where I learned laparoscopy surgery, because laparoscopy was just coming in there. And then I was, one of the first ones to get trained in that. So I had to hold the camera for 20 adult surgeons. I mean, 20 cases done by adult surgeon before I could even put my hands on it. So that is something which, everybody who comes in, I mean, you may not get a chance to start off with, laparoscopic surgery right in the beginning. It doesn't matter. Whoever is doing it, even if it is an adult surgeon, doing an adult appendectomy or a cholecystectomy, hold the camera. Now, there are scientific data available saying that watching somebody doing, you inadvertently use the same muscles as that person is doing. Like if you're suturing, inadvertently in your brain, the same stimulus goes to your wrist. So watching, you will learn without you realizing it. So hold the camera whenever you can, even if your junior is doing it. So it adds on to your knowledge. Second, get your own equipment. Now, when I started in, I didn't have my own equipment. I started not in Amrita, in another smaller hospital where I was sharing with, the gastroenterology surgeons. And there the problem is when you have posted a case and when you really need it, then the equipment is being used. So you have to postpone the case, you have to delay the case, and that the patient loses confidence in you. Now, especially in the private sector, the patient has connections. They come to that hospital, either they knew you or they know somebody in the hospital. So, when you know that you are at the mercy of the gastrosurgeon or the urology surgeon, then the patient will think then it's better to go to them to get the surgery done. So it's get your own equipment. Moreover, you feel more confident with your own equipment, just like having your own car. You know what the camera is going to show you. You know what, which needle holder is going to hold better. Now, coming to that, I'm not a fan of any particular equipment company, but what I want to tell is that, the camera of the different companies are different in the technical aspect. Now, for example, Stowe's camera, what I'm talking about is a part that you attach to your telescope. There, the signal is processed in that hand module, not in the camera that is put along with your tower. Now, this is patented by them. Now, the advantage is the digitalization, the digital image is being transmitted from your handle piece to the console. So there is no loss of signal there. As you know, digital signals can pass without getting distorted. So there is no distortion there. While in other companies, the analog signal, the camera gets an analog signal, and that is transmitted to the console, that the camera that you put in the, along with your tower. And it is digitalized over there and then sent to your monitor. Now, the problem is that during the transit from your handheld camera to the console, there can be distortion. So that is one thing that you have to consider. I mean, if you want, I mean, before you order both the equipments, now certain equipments like, if it like Striker, it has brighter colors. While as stores, the colors are a little muffled. So, I mean, every equipment has their own disadvantages. Like if you take, the telescope of Carl Stores, the number of fibers in that light channel is lesser compared to other companies, compared to say Wolf. Now, Wolf, there are more light channels. They call it high density anyway. So your telescope tend to last a little longer because of that. The image processing, the lenses are the same, but I'm talking about the fiber which carries a light. Now, so you can choose. Everything has its own. So you have to choose the best, what you think is best and what you can afford. Now, there are also cameras which goes about more than 1 crore where you can have ICGs. You can use it with ICGs because it has a filter. You can inject ICG, and like if you're doing a lab, hepatic resection, you can inject an ICG. You can know exactly where the tumor ends and the fibrous tissue starts. So you according to the budget, you can get your equipment. Now coming to robotics, I got trained in robotics. I got certified because at that point of time I thought in pediatric surgery robotic is going to take away everything, and then laparoscopy surgeons will be out of place. So I mean somewhere. So I got trained, but then what I realized is if I do the robotic surgery, it's going to cost about 1.5 lakhs extra. However, cost you cut in private setup, I'm talking about. Maybe in government institution, things are different. But here it cost you 1 to 1.5 lakhs extra. Even if you use 3 arms. So that the patient doesn't understand. Like somebody said, patient don't mind whether you cut with a steel blade or with a golden blade. He needs a cut. So the patient goes out and tell the neighbors and the rest of the people in the town or village where she come from, saying that Dr. Mohanebran did my pyroplasty and this is the cost. And the other person will tell somebody, I got this surgery done by LB. That also was keyhole surgery and it cost only this much. So he's going to hamper on my practice. So you have to tell the patient, even some patients are crazy. I mean, robotic is a status symbol for them. So they come and ask for robotic. Patients ask me whether I can do robotic, hypospadias. Because they got hypospadia done by somebody else and got a fistula. So they thought if I do robotic, there won't be any fistula. So patient concepts are different. So sometimes you have to care for that. But then you have to tell the patient this is the thing. And moreover, you're going to give a 5 mm or 8 mm incision, where otherwise you would have been giving a 3 mm incision. So you have to weigh all these before you,
Mohan, sorry, can I just ask you to briefly, because there are some other speakers and we
sure.
won't finish in time.
Okay. Dare to start and dare to convert. Some point you have to start. Maybe you start with putting pods and then start dissection and then you convert. Or if you get into a problem, you convert. But having a complication is much worse than doing a conversion. And record all your surgeries and review them. Even if everything has gone fine, I have a lot of CDs I have recorded. So after the thing, especially in the initial period, you review them and you'll always find a place where you could have improved. And lastly, let your colleagues and patients know you're doing it. What I mean is record your thing, present it, not in pediatric surgical meeting, present it in pediatric meeting, present it in general surgery meeting, let them know that you can do it. Like if I present it in a pediatric meeting that I can do laparoscopic pyeloplasty, then they are more likely to send the patient to you than to a urologist who will do it open. So let people know that you're doing it. Thank you.
Thank you. Thank you so much, sir. That was really inspiring. One very brief, quick question, sir. If a junior gets asked by a senior or his supervisor that, okay, you do this lap pyeloplasty in 3 hours, I can do it in 20 minutes. What should he answer?
That would have been a very relevant question about 20 years or 30 years back where anesthesia was risky. But these days it is not. I mean, you can give anesthesia for 8 hours. I have done surgeries for 8 hours. I mean, they just come out just fine. So the anesthetics are different, anesthetic techniques are different. So time during surgery is not the issue. It is a question of the total trauma that the patient is going to have.
Yes.
That is going to send them into catabolism for the next 3 weeks. So you do a laparoscopic, the total trauma to the patient is much less than when you do an open pyeloplasty.
Thank you so much, sir. Thank you. So now we'll move on to our next speaker, who is Dr. Sudhir Chandna. He will speak upon on the topic of relationship with community pediatric surgeons. I think that one of the previous speaker has touched upon that how we should collaborate with our pediatrician community. And Dr. Mohan Abraham has also stressed on presenting in front of the general surgery as well as the pediatric community. So,
good evening, everyone.
over to Dr. Sudhir, please, you can start.
Good evening, everyone. And I have been in a unique position in the sense that for first 14 years, I was totally in private practice. And after that, I got into a hybrid model where I became a teacher as well as was allowed practice, after 3 or 4 o'clock. So, but having said that, see, we always are dependent on the pediatricians for the patients to come to us. It's hardly ever that directly a patient will walk in, and say, I have a hernia. Or they'll first contact their pediatrician for whatever problem they have. Even if they have, say, something like intussusception, they have pain in abdomen, some red stool coming out, they'll think it's diarrhea and they'll rush to the pediatrician. So he's the one who will guide them to the pediatric surgeon. So it's very important for us to have, that relation with the community pediatricians so that they are aware of your presence and you get the patients referred to you. I think there's a 3-pronged strategy for that. I did when I came, and I had to perforce go into private practice, although I wanted to be a full-time pediatric surgeon, but somehow I just couldn't get a placement. In those days, there were very few posts. So what I found that one has to become an associate member of their association, the Academy of Pediatrics of your state and your city, so that you know what academic activity is going on, and you can attend those meetings so that people come to know you. And by a small talk, can be inserted into their meetings, which is not about very complicated pediatric surgical procedures or anything, but basic knowledge for them. Just say a talk on timing of various procedures. Because I found that like in those days, undescended testis, for example, some people believed it should be operated at 8 years of age. Some thought it should be operated at 5 years of age. I'm talking about the pediatricians, not the pediatric surgeons. Because when we passed out in 1988 or so, the age was around 2 years for operation. And then gradually it's now about 5 to 6 months. So that knowledge can be imparted to them in those meetings which you attend of the pediatric association. So I would advise for the younger generation to become an associate member of the association of their states, their city, and also the local level. The other thing which is very important is once the patient is referred to you for any problem, you should be very prompt in your feedback, which you give to the referring pediatricians or even the general practitioner. So that they know what is happening. They just want, they don't want any details of the procedure or what you're going to do, but you can say he has an appendix and I would be doing a laparoscopic procedure on him and, and let you know what happens. So that communication is very important. And the other thing is at the local level, in your surroundings, whatever small association of doctors is there, attend their meetings. Again, project whatever you are doing. As Dr. Abraham said that I'm doing laparoscopy, show a short video, be a part of their, social gatherings, chit chat with them, don't be aloof and, don't be a highbrow. So let them feel that you are a part of them, and that pays rich dividends in the longer run. So that's very important to be down to earth and to be friendly with them, even attend some social functions which they organize, like say Diwali gathering or something. Don't be, नहीं नहीं मैं नहीं आ सकता, बहुत busy हूँ, etc. So so it's really nice to give them a feeling that you are part of them, and it's a family which is going to give the best services to the patients, to the children they treat. So that's, I think, very important about the relationship with the community of pediatricians. And do we have junior people attending this meeting, or I don't know?
Lot of them, sir. Lot of them.
For them, I would like to say that ethics is the thing which you should hold while dealing with the pediatric community, of the pediatricians rather. Don't be like unethical. If you should not be forced to do which you think is not necessary. So very gently you should tell that no, this is not required. I'm not going to do it. Very, very common problem is of phimosis being thrust upon you for circumcision when it's really not required. So be ethical in your practice and be dedicated and hardworking. And I'll end by saying that a famous poet Shailendra, who wrote many songs for Hindi films. There are two songs which have been guiding principles for me. One is Sajan Re Jhoot Mat Bolo, Khuda ke paas jana hai. Na hathi hai na ghoda hai, wahan paidal hi jana hai. Or the second thing, the second song which he wrote was for Do Bigha Zameen, and Balrat Sani in the 1950s, and it says, Kuch to kahani chhod ja, apni nishani chhod ja. So work hard, leave something for people to cherish, and be ethical. Thank you.
Thank you. Thank you so much, sir. That was great words of wisdom coming from you. And I'm sure this interaction of pediatric surgeons with the pediatrician community is actually sometimes the magic sauce for the people who are working in private practice as well as in institutional setup also, because despite having all sets of skills and everything, sometimes their practice doesn't pick off. So this is the magic sauce. That is why we had decided to keep this topic for you, sir. Thank you so much. So now next up is Professor Kailan Rao. He has been my teacher and mentor. I have had the fortunate opportunity of working with him in close association. And as I said earlier, that pediatric surgery was an offshoot from the mothership of general surgery. Now, over the past 30, 40 years, pediatric surgery itself has become the mothership, from where all the offshoots into various subspecialties are now growing. And there is no way by which we can refute this fact that now pediatric surgery is undergoing that mitosis of division, where it will branch off and it will, what general surgery where 30, 40 years back, it has gone into that stage. I have requested Professor Rao to deliberate upon how a budding pediatric surgeon can choose a subspecialty and what exactly is the right time to choose that specialty. Rao sir, can you hear us?
Yeah, I can hear you, Ravi.
Please, over to you, sir.
Thank you. Thank you, Ravi and Mira, for calling me for this particular session. I'm so happy to see Professor Ravi Kumar, Ketan Parekh, Mohan Abraham, and Vikesh, and Ramesh Babu, and all the people. Okay. And I didn't make any particular slides, etc. And I would make a little extempore talk on the topic which Ravi asked me to talk on, how to choose a subspecialty in pediatric surgery and what is the right time to do this particular subspecialization. As I can see, for example, honestly, I'm a little bit lucky person amongst most of the pediatric surgeons, because after starting my in MBBS, say way back in 1974, I had an opportunity to work in institutions only, like Subsidiary Hospital, then PGI, then JIPMA, again back to PGI, almost for 42 years. And then, of course, I had a different way of life in the last 7-8 years where I'm in active practice in Chandigarh itself. Okay, so I never really had to really struggle with pediatricians or general surgeons, especially, as far as getting the patients, etc., etc. Now the question is how to choose a specialty in pediatric surgery is a little complex topic, as I can see. For example, in our era, Pena is one of the topmost example of choosing a small topic and working on it full steam, and then becoming a world famous and a major person for that particular topic. Of course, not all of us can really go to anywhere in that particular stuff, etc. But of course, my own journey, as I can see, ultimately in the last 15 to 20 years of my career in PGA itself, I end up doing only 4 or 5 surgeries, like, portal hypertensions, then primary PSRPs, esophageal replacements, and then rectal bladders for extrophy patients, etc. Because in institutional practice, you have so many, diseases where, you don't have really a great answers, etc. Some of the topics I try to, take up on my responsibility, and then of course things like neonatal surgeries with atresia. We are so happy, as Ravi Kumar has mentioned. We had one of the largest series in the world, I suppose. Okay, and of course, things like I settled on PUVs and VURs and pyeloplasties, etc., etc. Again, the question is when to choose a particular specialty or a specific type of cases which you want to do. As I can see, of course, nowadays the most glamorous topic is laparoscopy and robotic surgery is all right. I agree, I don't know about that. But I personally feel that laparoscopy and robotic surgery is a way of surgery. It's not, a particular disease, whether you do appendix or intestinal surgeries or colorectals, etc. It's a way of surgery. Okay, just as a technique, instead of cutting with, as Mohan has said, instead of cutting with a steel knife, you're cutting with something, just a putting and, keep doing with the laparoscopic or robotic instruments. It's a way of surgery. It's a technique of surgery. Okay, so you'll have to choose some specialization of a topic where you can excel yourself in whichever way you can, depending on that particular thing. My own journey of coaxing my colleagues, my juniors, into taking up various specialities, is no doubt that there's a lot of interpersonal relationships come into play. When I started somewhere in the 95, 96, when I became the head of department, I coaxed my 2 of my next colleagues. They were just not really willing to do a particular topic like urology or, plastic surgery or hypospadias, etc. They just so wanted to continue with all the topics. Fine. But subsequently, next generation of people, I could make them go into particular topics, like, Ravi has taken up fantastically into robotic and laparoscopic surgery. Prema also has done a lot of laparoscopic surgeries, etc. And Dr. Jay Mahajan has gone into plastic surgical topics and pediatric surgery. And Monica has gone into spina bifida, urodynamics, and all those such things, etc. And now Nitin is, in my department, in our department, taking up oncology surgery, etc. In institutional practice, it's not very difficult. But again, opportunities, after all, opportunities are not same for everybody. You get an opportunity, catch hold of that opportunity, and you excel yourself. Invariably, people will try to contribute to that particular pool of cases which you will be able to do. And that's the way to go about, rather than trying to say, no. Unfortunately, even in an institution, you have to do all emergencies. Okay. And you'll have to do bread and butter cases like, say, hernias or, orthopexies, blah, blah, etc. Okay. That you can't help it at all. And then another thing which probably, many people don't really stress upon is that unless you build up your skill in a particular topic, in a particular, case, or even this thing, then only you will excel. Okay. Now, after coming out of PGI, sitting in a private hospital, etc., I don't have to, do anything because my reputation speaks. They will keep coming. They'll keep coming. I have, to be honest with you, I I have removed all my poverty of 40 years in PGA in 7 years' time. Okay, nothing more than that. Then, as I said, laparoscopy, etc. Okay, all right. What cases are available to you? Obviously, you'll have to, choose topics which are available to you. Because, like, for example, Miglani in Amritsar is now, making a name for himself in hypospadia surgery. Okay, like that, depends on the opportunities you'll have to do, etc. Again, it's very difficult to really say, somebody takes urology, etc. Somebody takes oncology, etc. Or if somebody asks me now, I think there's nothing more rewarding than hypospadia surgery. You get hundreds and hundreds of cases. Even here in practice also, I have to give time for 6 months time, 9 months time, like that, for doing hypospadia cases. In other words, your own skill matters. How much you have won the reputation by giving to the society. That's what matters, etc. So I think I fully agree with Ravi that one has to take up a specialization when at least 5 years, do all the surgeries, don't refuse any cases, etc. Gain some knowledge of all the cases of how to do each case, etc. And then try to pick up 1 or 2 or 3 cases depending on what's the material available to you. And I think that's a way to go about in this current era of specialization and things like that. I think as Ketan has mentioned, and Sudhir has mentioned, and Dr. Raina has mentioned, people know, you can't, okay, in institutional practice, you can always, you're a big man and, people are coming to you for various kinds of things. Obviously, once you come out of the, 4 walls of the institution, it's your reputation, your skill that matters rather than anything else. Okay, I think with that, Ravi, I think I'll close my talk and I'll answer any questions if there's any. Thank you.
Thank you. Thank you, sir. Thank you so much. Since we are a little short of time, we'll move on to the next speaker. And the next speaker is Dr. Biswas, our President-elect IAPS. And we have asked him to talk on why the youngsters should take pediatric surgery. Now, this is something very delicate topic, because we have now increased all over India capacity of pediatric surgeons who are taking up pediatric surgery is increased, but it is still not enough. And we always want our general surgery trainees to come and work in pediatric surgery and choose pediatric surgery. So, Dr. Biswas, it's over to you. Sir, are you there?
Yes, yes, I am there.
So please start.
Thank you, Robi. My talk will be extempo, but because this morning only you told me that I have to talk on this topic. I think our viewers are already in pediatric surgery. So the topic may be changed, why they should continue pediatric surgery. I don't think general surgery trainees are here. One of the questions where I used to ask the first year MCH trainees in my setup, that why, in what sense the pediatric surgery is different from other surgeries, say general surgery. So many will tell it is a surgery for the children. It is like a watchmaker and a clockmaker difference, all these things. But I used to tell them that you are treating the future. Remember, you are treating the future. Your all actions should be regarding that. Your surgery and then surgical, other thing. You are like a gardener or florist whose success is tendering a bud to bloom fully. So that is the essence to me of pediatric surgery. And if I tell why I have taken up pediatric surgery, initial days when I was young, I thought the general surgery is going to be confined to abdomen. In pediatric surgery, I can have access to almost all from top to toe. Well, that concept is now changing. We are thinking of taking out subspecialties and other things, but it was to me like that. So my message to the youngster is that in your initial career to survive, if you are not in a job, you have to do all the things, whatever you go. So you be jack of all trades. But after a certain time, when you are established, try to be master of one. So there are plenty of examples in our association, like our present president, who is he is a reputed, internationally reputed pediatric urologist. And like VBS Chandrasekharan, who is an internationally reputed hypospediologist. Not that he is not doing other things also. So this may be the future, and the ultimate satisfaction and peace of mind, all these things will come not from money, but from curing your fellow beings who are born with certain congenital anomalies, and you are the best satisfaction you are treating them. Even the malignancy patients who are adult now, and when they will come to invite you, their sons or daughters ceremony, first year or Annaprashan ceremony, you will be that will be of immense sense of happiness and gratification that I have done something. So this is in short, and there are this is not a very confined subject. It is a very broad specialty subject, and you can tackle all the things. It is like swimming in a vast lake, not in a swimming pool. So with these few words, I am stopping here. I don't know, Vikesh can tell, my MSR oration was last year was on pursuing life as a pediatric surgeon. So whether it has been uploaded in IAPS
I will check.
video
I'll
repository,
check
I
and
don't
will
know.
share.
That one can consult also. Thank you all. Regards to my seniors, and thanks to the organizers. Thank you.
Thank you, sir. Thank you so much. Thank you for all the words of wisdom. And now we come to the ladies. I have deliberately kept them in the end so that we can give them the advantage of maximum time and, give them all the opportunity to listen to them. We have Dr. Meera with us, who will speak with the ever-growing power of women power in the IAPS and the pediatric surgery community and how it has changed in the last few years. I'm sure all of you must have observed that now more and more women pediatric surgeons are taking up pediatric surgery as a career. And even in my department, almost 50% of my residents are females. So this has been something which has changed. The trend has changed. And Dr. Meera will speak about it. Madam, over to you. Dr. Meera is there in the meeting? She was here.
She's muted.
She can unmute if she wants.
Yeah.
Yes, we can hear you now.
Okay. So thanks, Ravi. It's been great listening to everyone else. And yes, we've all had a struggle. And I've grown up, there were times it was frustrating that we were in the private sector. We didn't have access to a scope. And a contemporary like KL and Rao would present valves. And I said, don't have a cystoscope. So the first thing I had to invest was in instruments. And there were various things that one came across, and somebody would tell you to do a venesection but wouldn't tell you to do a hernia because they said that's too small for you. But venesection, yes, and you could be struggling for 2 hours with the light and with this thing. And at the end, if you charge 500 rupees, they said this was way too much. So that was life. But yes, nevertheless, I think if you persist and you go on, the doors open slowly and surely. And there was a time, I mean, I'm not going to say there was specific incidents when one SpO2 monitor was available in one hospital, and the priority was given to a urology surgeon who was doing a TUR, and I had to do a bronchoscopy. So I said, okay, let's stop it here. Who has priority to the SpO2 monitor? If you are not going to give it to me, this patient is discharged and now. And that, people said, you just starting your career. How can you do this? I said, but somewhere you have to put your foot down. Otherwise, nobody will listen to you. So I think these were the little things that I came across. But meanwhile, let me just give you a message from Dr. Shanti Talwar, because she's not able to join, but she did speak to me on the phone. And she said that please give my regards to everybody. And she has written a book where she has detailed all her struggles from Lahore and coming here, and how she developed a department, and how she came to PGI to do her MCH. And there is no question that she struggled her way through to develop now what is known as one of the best departments in Delhi at Maulana Azad. So I think that was something that she struggled and she made it. Similarly, there's another incident Dr. Taneja once said, Sumedha Taneja, some of you will know from Lady Harding and Maulana Azad. She said, both my husband, who was a surgeon, and me, we walked home, and he said, okay, what's for dinner? She said, what do you mean? We both have walked in together. You can't ask me these questions. Give me some time. I've also worked the same hours and come. So that was a laugh. And basically, we have other struggles to face at home. The house still runs. And even though today's men are involved and have come equal, holding hands and helping us through, but it all didn't happen in a day. It all happened slowly and surely. So I think the future is bright for pediatric surgery, and more women should come in, and we should be equal partners, not expecting anything special. That is something that I'm very clear about. We should expect and do the same facilities and be in the same competition as men. Thank you. That's it, Ravi. I think you're muted now.
Yeah, sorry. Thank you. Thank you, Dr. Meera. Thank you so much for your words of wisdom. And we'll continue on this topic with Dr. Saroj Churamani Gopal. She is a highly accomplished pediatric surgeon who has served in so many various capacities, including the vice chancellors, head of the departments, and the president of IAPS. So we have asked her to speak on the specific challenges which she has faced as a woman pediatric surgeons, and similar things which were there around 30 years back when she started her career, and how the situation has changed over the period of years over the past 3 decades. Saroj madam, are you there? You can
Yeah,
start.
I am there. Thank you, Ravi. I am so
Ma'am, you are muted. Can you unmute yourself? Yeah. Please
just a second. Am
yeah,
I audible now?
Yes, you are audible now.
Thank you very much, Ravi, to have invited me on this very special meeting, which is being held at 50th anniversary of IAPS. What a great pleasure. And I think we all need to compliment you. This topic of joining seniors with the loving younger colleagues is a great idea. And I think Meera was the one who initiated it about this idea. Now, about the struggle, I would like to say that it is good that I am a woman, and it is said that for being a good surgeon, there are 5 things which are needed. One is a lion's heart, and last one is the lady's hands. So I am as a lady, we are fortunate to be, and then of course, by nature, every lady is loving towards children, and that also is a great compliment that more and more ladies are attracted towards pediatric surgery. Now, the past. The past of pediatric surgery, I would like to say, when I was a young student, MS surgery, would you believe that with a condition like anorectal malformation, if the diagnosis is high type anorectal malformation, the in those days the death certificate was to be signed not just by the resident but had to be signed by the senior resident SRO, and the SRO in advance would sign a patient who is born with anorectal malformation high type where the colostomy is done. So the days were that I did not see for 3 years a single baby having survived with colostomy. Then one day I became into regular pediatric surgeon and joined back at Varanasi. There the top patient, tracheoesophageal fistula, the anesthetist refused to give anesthesia, saying that क्या फायदा है, patient तो बचते नहीं है. I kept on requesting him. He did not comply with. So I had to go right up to the vice chancellor to get the baby operated under anesthesia for esophageal atresia. And those diaphragmatic hernia cases and all neonatal abdominal surgery, we were doing it under local anesthesia. So that was the kind of time with the pediatric surgeons faced in the beginning. But fortunately today, of course, I could boast that Pediatric Surgery Center at Banaras Hindu University is as good compared to anyone in the whole country and perhaps even in the world. So the challenges that we have today is that we have to be all competent in doing minimal access surgery because it is the patient who needs it, who wants it. If you are not able to do it, he would just buzz away. So minimal access surgery is the need of the day. Every pediatric surgeon has got to learn it. I would also like to say that apart from the coming challenges of fetal surgery, we have to advance. We can take also help of the artificial intelligence incorporated into modern practice of pediatric surgery. With those few words, I would like to thank you again for having invited me for this talk. Thank you.
Thank you, madam. Thank you so much. And it is really nice to hear from you and all the other previous speakers, and especially the last two speakers who spoke about the women in pediatric surgery. This is something which has radically changed in the community of pediatric surgery, where we have now so many, highly achieving female pediatric surgeons. So we are really honored to have you. And so we are at the end of this structured talk from all our seniors. I had planned that we would ask one or two of our junior or the mid-career pediatric surgeons who are here in this meeting. And I actually told them to ask any open-ended question to this forum. I would ask Dr. Ankur. Is he here? Dr. Ankur Mandalia?
Yes, sir. Good evening. I'm here.
Ankur,
Yeah.
now you are free to ask a question to all this set of 8 speakers who have deliberated on the diverse range of topic. So you are a budding pediatric surgeon. You have accomplished so much with your institutional practice, and you have something to ask which can enlighten the rest of your fellow colleagues. So please go ahead and ask your question.
Yeah, thank you very much, sir. And it is a great experience to listen to the pearls of wisdom from everybody. Thank you, IAPS, for organizing this. I think this is one of a kind event. And what I wanted to ask as a mid-level consultant now is over the years, how have you managed the work-life balance? Like more and more work engrosses us every day as we go further in our careers. Other than pediatric surgery, also we do a lot of administrative work and in institutes also research work, etc. And you get busier and busier in your family lives. So, what is the secret behind staying fresh, both for your family and for the work, and how to achieve this work-life balance so that we don't get burnt out? So I like comments from all the seniors, and this is a question which plagues my mind every day now.
Yeah, yeah, very,
Yeah.
very pertinent question. So, can I ask Dr. Rana
Can
to
I interrupt you, Ravi? As a
yes,
work-life balance, I'm going to show you 3, 4 pediatric surgeons who are sitting with me. Come on. We are all enjoying pre-conference. Come here. There are, call the others. Can you?
Hi, everyone there.
Hello,
So,
sir. Hello.
they are
Hello.
they are doing the practicals of work-life balance scheme.
Yeah, this is Anna.
Hi, sir.
I call this.
Nice to see
Usually
all of
not
you.
we just say, while I've joined the meeting, they're doing the work-life balance.
Hi, Dr. Manglani.
Yeah. Can I
Hi.
request Rana sir to please say something about this question, very pertinent question which he has asked.
Yeah, what Ankur has asked is, number one, if you are feeling something bad, take it out from your heart. Whether you are in the house or in the hospital or being to the patient, because everywhere you may find somebody who may be abusing you. And that is what hurts you, number one. Secondly, when you do something and the patient dies, I remember myself that I used to become very sad. My wife said, I said, no, I don't want to have food. So she said, what? Then she said, look here, have you done the justice? I said, I did whatever best I can. Then you forget about it. It was not in your hand. Because that hurts you and you are always depressed. So first thing you think that whatever you have done it, we have done it sincerely. So don't worry about it. And analyze it if you have done some mistake, correct it in the next उसमें. है ना? And family. Remember one thing, you have to take full care of your family. About this thing, one thing, what happened that we had a ban on practice. The chief secretary has come and everybody were talking about it, how to open the practice and all that. I was just keeping quiet. Then in the last, he asked me, why did you keep quiet? I said, I had the different view. I said, what? See, God made it 24 hours of your life. In that, 8 hours you need for rest. 8 hours you need to work. And another 8 hours are being given, allotted for your family. Now, when you want to do it, if you are in the government institution, 8 hours are for that institution. Either you will try to skip away from that work and do your practice. This is one. If you do it there sincerely, then you will be skipping from your family duties. Even if you attend your family duties, you will be doing from your rest work. So what will happen? Your health will be finished. So balance it and do it in a way that it doesn't overburden you. है ना, वो बोलते हैं ना कि आधी जिंदगी तो आपने पैसे कमाने में लगा दी, आधी जिंदगी जो है उसका इलाज करने में लगा दी. So this should not happen.
Thank you.
बिल्कुल ठीक
Thank you so much, sir.
Thank you. Great answer.
So just to tell you, we are all sitting here and
yeah, we can see
we
your
just
gang.
see
We can
5
see your gang
pediatric
of
surgeons.
Ravi, if you permit, can I ask one question to all the seniors here?
Yes, Vikesh, please go ahead.
I am touching the age of old, what Professor Ravi Kumar, young old, another 12 years to go. But I would like to ask all the seniors here, when you are between 50 and 60, right now I'm 48, but I want to plan it about I'm going to do after 2 years. How should you proceed? By this time you already have earned good amount of money, fame, and worked for your society, for your association. still want to be active, but at the same time, how should you plan your life for those 10 years when you are about to touch 60? This is my questions.
Vikesh, you choose. I think you can choose your target from our next speakers.
One of the, inspiration here is Dr. Ketan Parekh.
Yeah.
And he's so dynamic, and right at this age, he made an application which is thoroughly impressive, sir. So, sir, and I worked as secretary with him in PESI also. So I have close association with him and a lot of respect. Sir, could you guide me, please, sir?
Hi, Vikesh. Sorry, can you hear me?
Yes, sir.
Yes.
Yeah, so I think I can't say that I really planned what I'm going to do from between 50 to 60. Continued my work. I had really not planned to retire unless sort of if I don't have enough work or I'm not fit for doing enough work. But I think post 65, one has to consider retirement gradually at some stage. And now I've started considering, and the main reason is not because I am not able to do work, but I would like to do a lot of other things in life. And I think that is an individual choice. I would like to do a lot of things. I would like to travel. I would like to do many things. And if you remain stuck with pediatric surgery, then it becomes difficult to do other things. So now I am, of course, as you said, the app was actually a product of COVID, so it was pre-65. But then there was no work, so that happened during COVID. And that is something again on which I want to work. So I want to do a lot of things. And I think I've done my share of pediatric surgery. Still, of course, I'm continuing. I'm not that not continuing, but I have definitely cut down, and I'm comfortable cutting it down because, as I said, I would like to do other things. But there are others who would possibly, I know of other colleagues who are so involved with pediatric surgery that they cannot think of anything else, and then fine. I mean, it's good, they can continue. But I am not interested in continuing in a very active way. That's my choice. That's more my choice. Not that I have anything against it.
Thank you.
So,
thank you.
One last question. Prabhu is there. Prabhu, I had asked Prabhu to ask a question from any of our seniors. Prabhu is trained in pediatric urology and is a very active member of IAPS, one of the younger, bustling with energy kind of person. So, Prabhu, shoot your question, please.
Sir, thank you for the opportunity, sir. First of all, asking me to ask the question. Sir, I have right now I'm into a corporate setup. My question to all the seniors, like who has already traveled the distance, is that how to handle corporates in three aspects. That is, everything is time bound in corporates. For every surgery, every procedure, every patient coming in, everything is time bound. So one question is how to handle this time bound entity. And second thing is how to handle the balance sheets in corporates, which they are more focused on. And the third thing, how to handle the corporate politics. So this is my question, sir, for who are into the corporate. Yes.
So I think we have Dr. Dasmit on the screen. I think he is the best person to answer this because he's working in successfully working in one of the biggest corporate setup. Dasmit, sir.
Yeah, thank you. See, I think nothing works like success. The more successful you become, the more listening that they will do. There's no need to get scared of corporates. There's no need to think that they can throw you out. They can't. They are also dependent on you. Yes, they do manage to dictate their terms, but a very good, honest, clean practice, I think, really works in the long run. And nothing works like having your own patients. You should be the one who is bringing the patient, and the hospital should feel dependent that so and so is bringing the patient. And I think that's the simplest way to have the corporates under your thumb. That's what I've been doing. I do not have any marketing. I do not have any, I mean, any marketing by way of giving any cuts or anything. I've never had the need to do it. I had never wanted to do it. And
have successfully remained completely insulated from that kind of a thing. My practice was based on directly reaching the minds of the patients and their parents. I would say the success of practice is just bypass the middle people. Middle people are generally the pediatricians and other doctors. You make yourself so big, you make your name so big that sometimes nobody has a choice. They just have to come to you. And that's probably what works. The way I was able to reach people directly was by way of, any success story. If I've done some particular surgery very well, the press people are also interested in selling their newspaper. They are always interested in something new you have done, something for the first time you have done. So they are also interested. So if you have a good rapport with them, and you just tell them, okay, I have done such and such a case, and the patient is doing really well. If they start getting interested in your cases, and pediatric surgery gives us an opportunity. There's such rare cases, and that immediately they catch on. They do some study, they come back to you, they go and interview your patient, and they will put it into the newspaper. And that really works because it establishes a name. And earlier, I think the earlier generation used to look down upon people's name, the doctor's name coming into the newspaper, that you are marketing. But I think that was not a very good idea at all. You are marketing, of course. It is an indirect way of marketing, but it's also a genuine marketing, because by that you make sure your bills are kept down, because the patient is you are not having to share your money with anyone. You can give that much of discount to the patient. So you are sharing, your reputation remains absolutely clean. Even the CT scan center, radiology centers, the other centers, they say कि वो तो cuts लेते ही नहीं है. So there is always a group of people in every city who are against this kind of cut practice. They become very, very strong supporters of you. वो भी नहीं लेता है तो उसी के पास भेजेंगे. So these are different ways of marketing. I mean, it's the reality of the situation, and we have to face it. I have been able to successfully keep away from it, and I think it works. So by direct marketing is what you have to do. So you make your name so big that the corporates don't have any choice, and that's what you should aim for.
Thank you, Dasmit sir. Thank you so much. So we are at the end of our structured program. Actually, at the end, I would ask Professor Ravi Kumar sir if he is still with us. Sir, are you there? To just, if he can say something or add something from what already has been said by so many speakers. Sir, we just love to hear you, so we want you to talk again. Can you hear us, sir? Ravi Kumar sir.
Voice नहीं आ रही ना.
Mute है.
I don't think sir can hear.
Okay, can you unmute? Can you unmute him, Ravi?
Yeah, I have asked him to unmute, and then he can click actually if somebody is helping him.
You can't do it from your side?
No, he has to unmute.
1 minute.
Yeah.
Yes, we can hear you, sir.
I can hear you. I'm very happy to see the whole lot of people giving their experiences and the excellent review, how they have fought their way to build up a department of pediatric surgery and then isolate them from the general surgery professors and then start the department and bring it to great heights in each department. And there are some genuine concerns of the people who are doing excellent job, how to manage the life balance. Primarily, life balance is wife balance. I mean, if you have a wife who will adjust with you, with all your whims and fancies, like my wife, for the past 57 years, she has been with me. And then I don't think you will have any problems in life. Now, the next question that was asked was, Dr. Vikesh said, at 42 years, and then you got only about 8 or 9 years, and Dr. Ketan Parekh said, you will stop working when he was at 65 years of age. You won't believe that my last hypospadias repair that I did was when I was 82 years and 3 months. And then when my father-in-law, who was doing a lot of eye surgeries at the age of 86, then I told my daughter, my father-in-law has done cataract surgeries at 86 years. Then she said, Ayo pavam patients. That means poor patients, she said. I mean, saying that at that age you should not do surgery. So, but overall, see, I have seen throughout the world, except South America, every part of the world myself and my wife have gone through. I believe in the dictum of Khushwant Singh. Khushwant Singh said, the money in the bank is not yours when you become old. Don't bequeath your property to your children when you become old, because at that time they are also doing extremely well, and therefore you spend on yourself. Now, one of the Australians said that Indians live for their children, the children live for themselves. I mean, and as children live for their children, and none of them live for themselves. So whatever money that you have earned, you go around the various places, both in India and abroad, enjoy with your wife, the children will take care of themselves. And then you continue to do your job till your hearing is good, your hands do not trouble, I mean, your eyesight is good, and you are up to date with the knowledge, and the people also will believe you. I mean, people believe you that you can do a good job. You continue to do the job. You find that Michael DeBacchi was operating when he was about 91 years of age. Then Danton Cooley, he did the artificial heart when he was 80 years past. And then, Anthony Quinn, and then he is a part of Gregory Peck, Anthony Quinn, and David Dimon, who formed this Guns of Navarone, where they acted that. Anthony Quinn got married when he was 82 years of age and had a child. This child was biologically proved to be his. So I think you have got a vast field for you to go ahead. And at the age of 45 years, Dr. Vikesh, you didn't have to bother. You've got another 40 years of life, very fruitful life. And I wish every one of you to have this. I mean, all pediatric surgeons will live long. I had been to the 80th birthday of Dr. Upadhyaya. I was there for the 90th birthday to Dr. Subir Chatterjee. I was there to felicitate Dr. Subhash Dalal when he was about 90 years of age. So we are all gifted with, and now I am 87 years of age. We are all gifted with good life, I mean longevity, and then I am 100% sure all of you will do extremely well, and then go ahead both in your profession as well as in your personal life. Good luck to you.
Thank you. Thank you so much, sir. That was really great. So in the end, I would request Vikesh, followed by Dr. Ramesh Babu, to say a few words of thanks and gratitude to all our members and all the participants. Over to you, Vikesh.
I have said enough, but one thing I would like to disclose here, that why I chose Meera Madam and Ravi here to moderate this session. So the reason being, these two are the most lovable people of the IAPS. And Meera Madam, you are loved by most of the men, and Ravi, you are loved by most of the youngsters. And you are, of course, both of you are favorite of our respected seniors here. Thank you for conducting this session so nicely. It is a memorable session for all of us. And of course, the thing which I was personally missing was the blessings of elderly people, seniors during the 50th IAPS Con. That deficiency is no more there. And I'm very sure 50th IAPS Con is going to be a very successful event, which is purely blessed by all of you. Thank you.
Dr. Ramesh Babu.
Perfect. So, yeah, I mean, this is so nice to have so many people here. I was trying to summarize it for various people who joined at different points of time, mainly for the youngsters, about what I've listened over the last 2 hours. Basically, a lot of people stressed that we should have the good rapport with all other departments and all our make friends with everybody. They also stressed that we can actually bypass the pediatricians if we have friendship with many other departments and many other colleagues. So they also said again that we have to have the channels of communications with the parents, and we should also keep on improving our skills, whether it is a laparoscopy or minimally invasive surgery or robotics. We should acquire new skills and also make a noise about your skills wherever you go. And they also said that we should develop a niche area. It doesn't just have to be minimally invasive. I mean, we have people who are doing spina bifida great work. We are doing extroview work. There are people who are focused on several areas, hyperspadias. So a lot of areas are there to, make yourself known. And they also stressed on getting instruments so that you get the enough freedom. And they stressed on adopting change, like for example, robotics or AI, any development. We have to keep evolving with the time, they mentioned. And they also mentioned about the work-life balance, also at the same time, don't stretch the limits too much, but keep your life active, keep involved, keep engaged. And as you age, you explore your passion, and then, make sure that you live your life fullest. I mean, these words of wisdoms by the seniors are like gold. We don't get these days. And the Golden Jubilee IAPS Con is really blessed today because of these words. And I thank them all for the words of wisdom. Thank you all.
Thank you. Thank you, Dr. Ramesh. So again, once on behalf of everyone, I would thank and for all your guidance, for the unwavering dedication you have shown. We certainly look forward to build up on the legacy which all our seniors have created and scale new heights. So with this, with the permission of the president, can we close this session now?
Thank you. Yeah.
Thank you. Thank you, everyone. See you soon. I think
Thank you,
it's
everyone.
it's an explosive start to the 50th IAPS Con.
Thank you. Thank you, Dr. Ravi. I would
stop.
like to pay my regards to Dr. Raina, please. Churamani here.
Pardon?
Dr. Churamani here was like to pay my regards to Dr. Raina.
Yeah. Thank you very
After a
much,
long
madam.
time.
Thank you, madam.
Thank you, Vikesh.
Thank you so much.
Thank you.
This is really Vikesh's brainchild. So all the credit goes to him to make this session alive and active. Okay.
Thank you.
Thanks to all the organizers.
Thank you.
Thank you.